Over the past decades, minimally invasive glaucoma surgery, or MIGS, has fundamentally transformed glaucoma management. Once reserved for more advanced disease, surgical intervention is now performed earlier in the disease course, often in younger and otherwise healthy patients. In this context, long-term safety has become a defining factor in technique selection. While numerous studies have compared the efficacy of MIGS techniques, often suggesting broadly comparable outcomes, detailed evaluations of their safety remain scarce. This systematic and narrative review examined the complications reported across all studies published on major MIGS techniques over a 10-year period between 2014 and 2024. Following PRISMA methodology, nearly 5,000 articles were screened, and 401 studies were included, representing almost 40,000 eyes and 69,000 eye years of follow-up. The rates and nature of complications varied widely across techniques and could be grouped into three categories. Firstly, common events such as high FEMA or intraocular pressure spikes, typically mild, self-resolving, and observed across most techniques. Secondly, less frequent but clinically significant events including severe hypotony, macular edema, and progressive endothelial cell loss. Lastly, technique-specific adverse events that may require special consideration. Examples included Descemet membrane detachment in ab interno canaloplasty, choroidal detachment and pupillary distortion after Miniject implantation, supraciliary effusions following trabeculotomy, progressive peripheral anterior synechiae with hydrous implantation, and deep or buried stents after iStent inject implantation. All MIGS techniques produced adverse events, but trabecular bypass implants and ab interno canaloplasty demonstrated the lowest rates of serious adverse events and the least anatomical disruption, helping preserve structures for future interventions. However, heterogeneous definitions and inconsistent reporting limited comparability across studies. Common events such as high FEMA were often inconsistently documented, and examination-dependent findings, such as endothelial cell loss, peripheral synechiae, or supraciliary effusion, were frequently underreported. This review highlights the need for standardized safety definitions, harmonized reporting frameworks, and long-term follow-up. As MIGS becomes an established early interventional strategy, when other factors are comparable, tissue-preserving approaches may offer a safer and more sustainable option.